بسم الله الرحمن الرحيم. بهذه المحاضرة حنشرح النوع الثاني من الفوتوسنسيتيف رياكشن اللي هو Idiopathic Photosensitivity Disorders. This idiopathic group include the photosensitivity disease for which no cause is known. These disorders are not associated with external photosensitizers. example عليها اللي هي Polymorphous light eruption. Polymorphous light eruption مختصر معناتها BLE or PMLE is the most common form of photosensitivity. A history of polymorphous light eruption can be elicited in between 5 and 20% of adult population in Northern European white persons. All races and skin types can be affected. The onset is typically in the first 4 decades of life. Females outnumber males by 2 to 1 or 3 to 1. Pathogenesis هي unknown cause. ممكن family history may be elicited in 10 to 50% of patients. Some investigators report that 10% to 20% of patients with polymorphous light eruption may have positive anti-nuclear antibodies or also a family history of lupus erythematosus. Photosensitive SLE patients may give a history of polymorphous light eruption-like lesions for years before the diagnosis of SLE is made. Polymorphous light eruption patients should be followed for the development of symptoms of SLE. نجي على clinical features. The eruption may have several different morphologies من اسمه polymorphous, although in individual patients the morphology is usually constant. يعني هو different morphologies وبالبيشنت نفسه يكون ثابت عادة. Scarring and atrophy do not occur in darkly pigmented races. However, marked hyperpigmentation, both inflammatory hyperpigmentation or hypopigmentation may be present. نجي على variants of polymorphous light eruption. ممكن تكون papular or erythematopapular variant, which is the most common one اللي بالصورة هي papular variants. ممكن papulovesicular, eczematous, erythematous, or plaque-like lesions more common in elderly patients and may closely simulate lupus erythematosus with indurated erythematous fixed lesions. عندنا variant اللي هي تكون pinpoint papular variant or micropapular variant اللي هي هذه بالصورة has been observed in African Americans closely simulating lichen nitidus but showing spongiotic dermatitis histologically. Polymorphous light eruption thin eruption يعني هي مجرد type أو variant من polymorphous light eruption بدون eruption مجرد pruritus. Without an eruption may be reported. Some of these patients will develop typical polymorphous light eruption later in their life. نجي على timing and triggers. The lesions of polymorphous light eruption appear most often 1 to 4 days after exposure to sunlight. Although patients may report itching and erythema during sun exposure and development of lesion within the first 24 hours. يعني هو عادة 1 to 4 hours بس ممكن develop a lesion within the first 24 hours. A change in the amount of sun exposure appear to be more critical than the absolute amount of radiation. يعني الاختلاف بالتعرض للsun exposure هو اللي يسببه أكثر ما أنه الكمية أنه أكثر ما التعرض للأشعة مع الشمس. The eruption appears most frequently in the spring. The eruption often improves with continuous sun exposure اللي هاي ظاهرة نسميها hardening. So patients may be clear of condition in summer or autumn. Area of involvement هي sun exposed area مثل الفيس, the area of the neck or the chest, neck and arms. However, areas protected during the winter, such as the extensor forearms, are particularly affected, whereas area exposed all year face and doors of the hand may be relatively spared بسبب hardening. The unusual variants of polymorphous light eruption هي juvenile spring eruption of the year. Occur most frequently in boys aged 5 to 12 years, but may also be found in young adult male. It's present in the spring, often after sun exposure on cold days but sunny days. The typical lesions are grouped small papules or papullovesicle on the helices. Lesion may form visible vesicles and crusting. عادة هي self-limiting and do not scar. UVA is the inducing spectrum. Some patients also have lesions of polymorphous light eruption elsewhere. The histological picture is identical to that of polymorphous light eruption. عندنا نوع ثاني اللي هو spring and summer eruption of the elbows occur in adults equally in men and women. نرجع الهistology. يكون perivascular predominantly T lymphocyte infiltrate is present in the upper and middle dermis. There is often edema and endothelial swelling with occasional neutrophils. Epidermal changes are variable, with spongioses and exocytosis most often observed. Occasionally, a virtual absence of findings microscopically may paradoxically be reported and has been referred to as post-inflammatory photodermatitis. نيجي على الأكشن spectrum of polymorphous light eruption. Varies possibly depending on different ethnic background of reported populations. UVA is most often responsible. However, UVB and both wavelength in combination are also frequently necessary. Patient often reports eruption following sun exposure through window glass, although rare visible light sensitivity can also occur. Typically, women are more sensitive than men to UVA only, and men are more sensitive to visible light. Men, although the minority of polymorphous light eruption patients, tend to have more severe polymorphous light eruption and a broader wavelength of photosensitivity. Differential diagnosis قلنا lupus erythematosus, photosensitive drug reaction, prurigo nodularis, and photoallergic contact dermatitis. Investigation. In clinical practice, the diagnosis is usually made clinically. ممكن histopathological examination, anti-nuclear antibody testing, على مود differentiating from others, or direct immunofluorescence. These investigations are helpful in distinguishing these diseases, اللي هي differential. Serological testing alone may not distinguish polymorphous light eruption from SLE because of the possibility of positive anti-nuclear antibody tests in patients with polymorphous light eruption. Lupus erythematosus may present initially with photosensitivity before other features of lupus occur. The photo testing may be required to convince patients that they are UV sensitive and will also determine the action spectrum. Photo testing produced a variable result. One protocol produced positive result in 83% of tested patients using 4 exposures of UVA, UVB, or combination in previously affected sites. Most patients react more in the affected site, and in some, lesion can only be induced in the affected areas. However, the light sources are not readily available and reported protocols vary widely. يعني مو وايد يستخدم التست. Other idiopathic eruption, example, sebaceous neutrophilic adenitis, تظهر على شكل erythematous, thyrsinate, plaques, عادة بالhead, neck, and upper chest, هي sun exposed area. Although it may be photo-induced, it may also be idiopathic, as in the cases reported in the genital area. هي ممكن تكون بالgenital area, فهذه ما ممكن تكون photo-induced. Timing has been reported in the first to second month of spring. In histology, neutrophilic infiltration of sebaceous gland occur. sometimes forming microabscesses. And the acute pustular folliculitis, the presence of follicular pustules distinguish the photo-induced cases from polymorphous light eruption. Location عادة recurrent eruption of head and neck. Causes may be photo-induced, viral associated, or idiopathic. It's resolved in most cases spontaneously in several days. نيجي على treatment. Patient education is important in management of polymorphous light eruption. Avoiding the sun. Most patients with mild polymorphous light eruption can be managed with broad spectrum sunscreens. It's using barrier protection and high SPF is critical that the sunblock contains specific absorber or blockers. Ecamysol, avobenzone, titanium dioxide, and zinc oxide. Of long wave UVA because this is the most common triggering wavelength. Sunblock containing more than one of these agents are more effective. ممكن يستخدمون derma-guard film, can be applied to the windows at home and also in the car to block the transmission of almost all UVB and UVA rays while allowing visible light to be transmitted. Degradation does occur, so the film should be replaced every 5 years. These measures of photoprotection are critical for all patients because they are free of toxicity and reduce the amount of and the duration of other therapies required. ممكن نستخدم topical tacrolimus ointment at night or twice daily combined with the previous measures for sun avoidance. And the use of sunscreen control polymorphous light eruption in many patients. ممكن نستخدم topical steroid frequently of super or high potency and in several daily to weekly pulses are necessary to control the pruritus and clear the eruption. ممكن نستخدم antihistamines for pruritus. Systemic corticosteroid in short courses may be necessary, especially in the spring. Hardening in the patient whose condition is not controlled by these measures. Hardening in the spring with UVB, narrowband UVB, or Suraline plus UVA can dramatically decrease the sun sensitivity of the patient with polymorphous light eruption, and up to 80% can be controlled with phototherapy. Systemic steroid, in the most sensitive patients, systemic steroid may be needed at the inception of phototherapy, يعني at the initiation of phototherapy. ممكن نستخدم systemic hydroxychloroquine sulfate 200 ل 400 mg per day may be used. It has delayed onset and best instituted in the late winter to prevent spring outbreaks. ممكن نستخدم chloroquine or quinacrine if hydroxychloroquine is not effective. But in general, antimalarials are inferior to phototherapy. أيضا ممكن نستخدم drugs اللي azathioprine, cyclosporine, thalidomide, or mycophenolate mofetil may be considered in most severe cases. If these agents are used in a patient considered to have polymorphous light eruption, an evaluation for chronic actinic dermatitis should be performed because patients with polymorphous light eruption rarely require these agents. هذا فيما يخص البوليمورفوس لايت eruption.